Sexual dysfunctions are a group of dysfunctions that prevent individuals from wanting or enjoying sexual activity. They can have a profound impact on a person's life and can lead to high levels of distress and anxiety. There are many factors that lead to sexual dysfunctions. Emotional factors include depression, sexual fears or guilt, past sexual trauma, and anxiety. Physical factors include pain and discomfort during sex. Additionally, drugs like alcohol, nicotine, or narcotics, premenstrual syndrome, pregnancy, the postpartum period, and menopause can all affect a person's libido and the ability to experience sexual pleasure. Sexual dysfunctions can be divided into 4 subtypes: lifelong or acquired, and generalized or situational. Lifelong is when the sexual problem has been present from first sexual experiences. Acquired applies to problems that develop after a period of relatively normal sexual function. Generalized is when the problem occurs across many types of stimulation, situations, or partners. And situational refers to sexual difficulties that only occur in certain contexts. In all the disorders, the sexual dysfunction should not be better explained by a non-sexual mental disorder, or as a consequence of severe relationship distress or other stressors, and it shouldn't be attributable to another medical condition. Additionally, the symptoms must persist for at least 6 months and should cause significant distress. Sexual dysfunctions can further be divided into 3 categories: male sexual disorders, which include delayed ejaculation, erectile disorder, male hypoactive sexual desire disorder, and premature ejaculation. Female sexual disorders include female orgasmic disorder, female sexual interest or arousal disorder, and genitopelvic pain or penetration disorder. And 3 common disorders, namely substance or medication-induced sexual dysfunction, other specified sexual dysfunction, and unspecified sexual dysfunction. First up in male sexual dysfunctions is delayed ejaculation, which causes either a marked delay in ejaculation, marked infrequency of ejaculation, or absence of ejaculation. The delay shouldn't be intentional and should occur almost every time the individual has sex. Second is erectile disorder, which causes marked difficulty in having an erection during sex, difficulty in maintaining an erection until the end of sex, or a decrease in erectile rigidity. Some common factors that can cause this problem include the health of the relationship, poor body image, or a history of sexual or emotional abuse, a psychiatric comorbidity or stressors, the individual's cultural or religious background, and medical factors. Third is male hypoactive sexual desire disorder, which is when there are few or no sexual thoughts or fantasies, and a low or absent desire for sexual activity. A desire discrepancy, in which individuals have a lower desire for sexual activity than their partners, is not sufficient to diagnose male hypoactive sexual desire disorder. The 4th male-related condition is premature ejaculation. This happens when ejaculation occurs within 1 minute of vaginal penetration and before the individual wishes it. There are 3 levels of severity: mild, when ejaculation occurs within 30 seconds to a minute, moderate, when it occurs within 15 to 30 seconds, and severe, when it occurs before individuals even start having sex, at the start of sexual activity, or within 15 seconds of penetration. Next up are the female sexual dysfunctions. First, female orgasmic disorder causes a delay in, infrequency of, or absence of orgasm. Alternatively, it can cause reduced or absent orgasmic sensations. The symptoms are experienced in most or all occasions of sexual activity. Many individuals require clitoral stimulation to reach orgasm, with only a minority of females being able to consistently experience an orgasm during penile vaginal intercourse. So, experiencing orgasm through clitoral stimulation, but not during intercourse, does not meet the criteria for female orgasmic disorder. Second, there's female sexual interest or arousal disorder, and that's diagnosed when there are at least 3 of the following 6 symptoms. First, there's little or no interest in sex. Second, few or no sexual or erotic thoughts or fantasies. Third, they rarely initiate sex and often refuse when others initiate it. Fourth, they usually feel little or no sexual excitement or pleasure during sex. Fifth, there's little or no sexual interest or arousal in response to sexual cues that may be written, verbal, or visual. And sixth, there's reduced or absent genital or non-genital sensation during sexual activity. Third, there's genitopelvic penetration disorder, which causes problems in one or more of the following 4 situations. First is difficulty with vaginal penetration during intercourse, or with tampon insertion, and this can occur only in some situations or in all situations. Second, there's vulvovaginal or pelvic pain during vaginal intercourse or penetration attempts. Third, there's fear or anxiety about vulvovaginal or pelvic pain related to vaginal penetration. And fourth, the pelvic floor muscles are tense or tightened during vaginal penetration. A disorder common to both males and females is a substance or medication-induced sexual dysfunction. Usually there's evidence that the dysfunction developed during or soon after substance intoxication or withdrawal, or after exposure to a medication, and that the substance is capable of producing the disturbances. Also, the disturbance shouldn't occur exclusively during the course of an episode of delirium. Other specified sexual dysfunction applies to presentations in which symptoms characteristic of a sexual dysfunction cause distress and impairment, but do not meet the full criteria of any of them, and the clinician chooses to communicate the specific reasons they don't. If the clinician chooses not to specify the reason, diagnosis is unspecified sexual dysfunction. Treatment for sexual dysfunctions can involve behavioral and psychological therapies, lifestyle changes, and medication. Behavioral and psychological therapies are designed to achieve a number of goals: treat sex-related anxiety, improve self-confidence and communication in the relationship, and ultimately improve the individual's sex life. The first treatment option is cognitive behavioral therapy, which focuses on dysfunctional thoughts, unrealistic expectations, behavior that decreases desire for intercourse, and insufficient physical stimulation. These sessions can include both partners, and homework assignments are often used. Psychodynamic sex therapy, which addresses underlying developmental and identity issues that impact sexual desire, is a short-term form of counseling, generally involving 5 to 20 sessions with a sex therapist. A typical session might be 1 hour every week or every other week. Other options include group therapy, talk therapy, and sex education. Second, regular physical activity, at least 60 minutes per day, has been associated with improved blood flow to the genital area, psychosocial well-being, and improved sex performance. Fatigue and stress can contribute to low libido and sexual problems for all sexes, so addressing these issues through mindfulness, yoga, or other relaxation techniques often results in improved sexual interest and satisfaction. Third is medication. In delayed ejaculation, medication is a last resort, and options include amantadine, which is a weak glutamatergic antagonist used in Parkinson's, buspirone, which is an anti-anxiety medication, and cyproheptadine, an allergy medication. For erectile disorder, phosphodiesterase 5, or PDE5, inhibitors like sildenafil or vardenafil are recommended. Sildenafil should be taken in initial doses of 50 mg orally on an empty stomach, approximately 30 minutes to 1 hour before a planned sexual encounter. Testosterone is an important regulator of sexual desire and sexual function in those with male reproductive organs, and as a result, combination therapy with a PDE5 inhibitor and testosterone has become increasingly common. In addition, several mechanical devices have been developed that utilize vacuum pressure to encourage increases in arterial inflow, but they should be used for only 30 minutes at a time. Intracavernosal injection therapy with alprostadil, a vasodilator, has also been used for purposes of inducing an erection. In male hypoactive sexual desire disorder, pharmacotherapy can include testosterone, methylphenidate, which is a stimulant medication, and bupropion, which is an antidepressant that doesn't lower libido. In premature ejaculation, management depends on the etiology, But SSRIs are considered first-line treatment, and they include paroxetine, usually 10 to 40 milligrams per day, sertraline, 50 to 200 milligrams per day, or fluoxetine, 20 to 40 milligrams per day. Topical anesthetics like lidocaine prilocaine spray have been reported to improve ejaculatory latency, ejaculatory control, and sexual satisfaction when applied topically to the glands of the penis 5 minutes before sex. In female orgasmic disorders, E. angustifolia, a medicinal plant, and sildenafil may be used in some cases. In female sexual interest or arousal disorder, individuals with low levels of androgens can receive treatment with testosterone or estrogen being recommended for desire problems that stem from vulvovaginal atrophy. Flibanserin, a drug that increases levels of norepinephrine and dopamine, and reduces levels of serotonin, can also help improve libido. And in genital pelvic pain or penetration disorder, botulinum toxin type A injections could reduce muscles' hyperactivity by blocking presynaptic cholinergic synapses and the release of neurotransmitters involved in pain perception. Topical treatments with amitriptyline, lidocaine, and nifedipine can be topically applied to treat vulvar pain. Vulvar vestibulectomy, or the complete removal of vestibular mucosa, is a well-established invasive treatment for some individuals. Now, after initiating therapy for sexual dysfunction, individuals should be seen for regular follow-up visits, approximately every 3 months, until the sexual problem has improved. Individuals may then be seen every 6 to 12 months, depending on the potential risks of the treatment selected. Treatment efficacy is best assessed by self-report of improvement of symptoms and achieving treatment goals. Alright, as a quick recap, delayed ejaculation causes either a marked delay in ejaculation, marked infrequency of ejaculation, or absence of ejaculation. In erectile disorder, there's marked difficulty in having an erection during sex, difficulty in maintaining an erection until the end, and a decrease in erectile rigidity. In male hypoactive sexual desire disorder, there are few or no sexual thoughts or fantasies, and low or absent desire for sexual activity. Next is premature ejaculation, where ejaculation occurs approximately 1 minute after vaginal penetration and before the individual wishes it. In female orgasmic disorder, individuals have a delay in, infrequency of, or absence of orgasm, or, alternatively, the orgasmic sensations are reduced or absent. In female sexual interest or arousal disorder, there's a lack of or reduced sexual interest or arousal in almost all sexual encounters, as manifested by at least 3 of 6 symptoms. First, there's little or no interest in sex. Second, few or no sexual or erotic thoughts or fantasies. Third, they rarely initiate sex and often refuse it when others initiate. Fourth, they usually feel little or no sexual excitement or pleasure during sex. Fifth, there's little or no sexual interest or arousal in response to sexual cues that may be written, verbal, or visual. And sixth, there's reduced or absent genital or non-genital sensation during sexual activity. And lastly, genital pelvic penetration disorder presents difficulties with 1 or more of 4 situations. First is difficulty with vaginal penetration during intercourse or tampon insertion. Second, there's vulvovaginal or pelvic pain during vaginal intercourse or penetration attempts. Third, there's fear or anxiety about vulvovaginal or pelvic pain related to vaginal penetration. And fourth, the pelvic floor muscles are tense or tightened during vaginal penetration. And finally, substance or medication-induced sexual dysfunction requires a disturbance in sexual function that's directly correlated with use of a substance or medication. Treatment options include cognitive behavioral therapy, psychodynamic sex therapy, group therapy, talk therapy, and sex education. Lifestyle changes include physical activity, at least 60 minutes per day, mindfulness, yoga, and other relaxation techniques. In delayed ejaculation, medication includes amantadine, buspirone, and cyproheptadine. In erectile disorder, sildenafil and vardenafil are recommended. In some cases, supplemental testosterone is used. In male hypoactive sexual desire disorder, pharmacotherapy can include testosterone, methylphenidate, and bupropion. In premature ejaculation, SSRIs like paroxetine, sertraline, or fluoxetine are used. In female orgasmic disorder, options include E. angustifolia and sildenafil. In female sexual interest or arousal disorder, individuals can receive treatment with testosterone, estrogen, and flibanserin. And in genital pelvic pain or penetration disorder, botulinum toxin type A injections could reduce muscle hyperactivity, while topical treatments with amitriptyline, lidocaine, and nifedipine can be applied to treat vulvar pain.